Hi, it's Christina Weng from Baylor College of Medicine, and I'd like to welcome you to the Retina TLDR, where we tackle the most topical issues in the retina space with leading experts in the field. It's my pleasure to welcome here today my colleagues and friends, Dr. Diana Do from Stanford, Dr. Nora Ladd from Duke, and Dr. Marian Munk from the University of Bern in Switzerland. These are three not only leading retinal specialists, and you know all their names, but they are three of the co-authors of the LIGHTSITE III trial 13-month data publication. And I'm delighted to have them as guests today. Diana, Nora, Marian, welcome. Thanks so much for being here today.
Thanks for having us.
Thanks for having me.
Thank you. It's my pleasure to be here.
It's a pleasure, ladies. Well, looking forward to learning about this novel treatment approach, but so let me take a moment to explain the catalyst behind this series. Did you ladies know that the average attention span is a mere 47 seconds? It's crazy to think about. So even though I encourage this audience to tune in for the entire conversation, we're going to start every interview with a TLDR. So Nora, on behalf of the group, what's your TLDR?
Okay, mine's the following. Photobiomodulation is the first minimally invasive FDA-approved treatment for dry AMD with VA loss, vision acuity loss, and it demonstrated an excellent safety profile and improvement in both clinical and anatomical outcomes in clinical trials.
Nice and short and sweet. So let's jump in. In 2023, we finally got our first two approved therapies for geographic atrophy. But as we all know here, these drugs did not demonstrate improvement in visual acuity, emphasizing the need to intervene earlier in the disease course of dry AMD. And that's exactly what photobiomodulation aims to do. Marian, what is photobiomodulation? And tell us a little bit about the Valeda light delivery system that was FDA cleared in November of 2024.
Photobiomodulation is a low light level therapy using different wavelengths to improve cellular function. And the Valeda system is actually the first CE marked and FDA cleared ophthalmic PBM platform for the indication of dry AMD. It uses three different wavelengths, red, yellow, and near-infrared, to target the mitochondrial cytochrome C oxidase, enhancing ATP production and reducing oxidative stress, inflammation, and complement activation in the retina. The aim is to improve visual function and potentially slow the progression in dry AMD.
Fantastic. Appreciate that overview. And Diana, I'm going to turn to you. Walk us through the LIGHTSITE III trial at a high level and maybe highlight some of the top line results for us, if you would.
Yes, this is an important pivotal clinical trial, and it was a randomized clinical trial looking eyes that had baseline dry age-related macular degeneration without the presence of choroidal neovascularization and without the presence of center-involving geographic atrophy. And then patients who were eligible were then randomized to receive active photobiomodulation or active sham treatment. And that's important. The sham treatment actually had lower levels of the light therapy and removal of one of the three wavelengths. And then we followed and treated these patients over actually a 2-year period. The primary endpoint was at month 13 and then also at month 21. And they compared the visual acuity over time. And the results did show that active treatment with photobiomodulation, on average, improved vision by about 6 letters. In the sham treatment group, there was also a mild improvement in vision, in about 3 letters, but it was statistically different between the active treatment and the sham treatment. And these benefits were sustained through 2 years.
Yeah, to your point, Diana, what I find really appealing about photobiomodulation is that the data suggests that it might unlock the cheat code that we're all after, which is earlier intervention and vision improvement through a non-invasive approach. But there also seems to be a diversity of opinions in the community regarding the technology. So let's talk through some of those points that I've heard raised by some of our colleagues. First, the mean baseline visual acuity was around 70 ETDRS letters, or approximately 20/40, which seems, maybe a little bit low for what you might expect for this cohort of 100 patients with early intermediate dry AMD. And this has led some to wonder whether the visual effects that we're observing are simply a regression to the mean. Nora, what are your thoughts on this? Is there validity to that point that's being raised?
Great question. I believe that the observed outcomes do represent a real difference between the sham group, which Diana went over. It's an active sham group, and the photobiomodulation group. The sham group had worsening of the visual status due to disease progression and conversion to GA. the PBM or photobiomodulation group showed significant improvements in best corrected visual acuity at all time points in the study, and also stabilization of visual acuity after the third treatment series. And this was by a mean of 6.3 letter gain from baseline. And these visual gains were maintained at 24 months with repeat therapy at 4 months intervals. So I do believe that these outcomes do represent a real difference.
Absolutely. No, thank you so much for that clarification. And we'll also learn more, obviously, with longer term data. So it's really exciting to have that potential. Mary, I'm going to ask you the second question, which is, when you're dealing with an AMD population, you're also concurrently dealing with a cataract population, right? And the manuscript didn't seem to explicitly state the prevalence of cataracts or the rate of cataract surgery during the study. Are there plans, Marian, for this data to be shared in the future?
Sure, I'm going to share them right away. So at baseline, actually, when we had a look at the baseline characteristic, 51% of the patients were pseudophakic, and the remaining 49% of the patient had some form of cataracts. We have to remember this is really an old patient population we are dealing with. And when we look specifically at the individual groups, in the sham group, actually 67% were pseudophakic, while in the PBM group, only 41% were pseudophakic. So in some, the PBM group had more likelihood to kind of progress or show worsening of cataracts over the course because the prevalence was higher. Over the course of the trial, 2 eyes had cataract surgery, 1 sham eye and 1 PBM eye, but both happened after the 30 months. And this is why this information is not shown in the 30 months data. And according to the protocol, these eyes were then excluded from the efficacy analysis and are only included in the safety analysis. But this will then be presented at the 24 months publication, which is currently in revision.
Fantastic. So that actually even gives more weight to the visual acuity outcomes because it was such a low rate of intervention. And that happened, as you said, after the study period, after that primary outcome. So that's really interesting to hear. One of the outcomes from the LIGHTSITE III study that I thought was intriguing was the decreased rate of new onset GA development, which I highlighted earlier. And that suggests that maybe this technology could also be disease modifying. At the same time, there was also a slightly higher rate of neovascular AMD noted in the treatment arm compared to the active sham arm. Diana, do you think that's a real signal, what we're seeing with the exudative AMD, patients that emerged?
Recall in this study at baseline, all of the eyes had to have some intermediate AMD, that is either medium or large size drusen, and many of these eyes also had pigmentary changes in the macular region. When we took a closer look at those eyes that developed choroidal neovascularization, that was 3 eyes in the active photobiomodulation arm, we see that they had high-risk characteristics. They had large drusen and they had RPE changes. And we know from our AREDS database that those eyes are more likely to advance to either wet AMD or geographic atrophy. So it wasn't a surprise that some of these eyes in the study over, a 1 or 2 year follow-up period might convert. When we looked at the active sham, we also saw that some of those eyes did convert too, but there may have been a slight imbalance with more of these high-risk eyes in the active PBM arm.
Fantastic. And again, I think we'll learn more also from the 2-year publication, which Marian mentioned will be coming out hopefully in the near future. I appreciate you ladies tackling some of those challenging questions with me, and I'm sure the community will really appreciate those insights. Just finishing up here, switching topics a little bit, this is a paradigm shifting treatment, not only medically, but also business-wise, because it introduces a new revenue stream from a practice management standpoint. Diana, how is this being executed right now? And maybe you can provide us some specifics with regards to, who's able to attain the device and how many sessions and how long do each of the sessions take, who's authorized to operate the machine, and maybe a little bit about the machine cost and what patients are being charged. Any insights I think would be really appreciated.
It's still early. Many retina specialists are acquiring the machine. Right now, it's being sold to retina specialists. In the United States, the machine costs approximately $70,000. And the interesting thing is some insurance carriers may be covering the therapy. So right now, it's advisable that physicians may submit it for insurance claim. Once it is denied, that beforehand there's a conversation with the patient to know that if the insurance is not covering, the patient should be responsible for the cost of the treatment. And in California, actually, the ophthalmologist, retina specialist, needs to administer the treatment because it is a medical therapy, and the rules may change state by state. So the retina specialist should check with their own individual medical board and state about who has to administer the therapy.
That's really helpful information, Diana. How long do the sessions take in general? Are they super lengthy, or is it pretty quick for the patient to come in and out of the office for?
Remember, the patient does not need to be dilated. Each session probably takes less than 5 or 10 minutes once their position and everything is taken into effect. And the treatment is 9 mini sessions over a 1 month period, usually on average 3 sessions a week. And then this is repeated quarterly. And we see from the data that this likely needs to be a chronic therapy because there was an extension study after the pivotal clinical trial. And we saw that when there was an intermission without treatment for about a year, the visual acuity benefits tended to diminish without continued therapy. So we see that once therapy is reestablished, then the vision increases again. So we would recommend that this is a chronic therapy to maintain the benefits.
Thank you for those insights. On a related note, Nora, how do you think this will change practice patterns when it comes to dry macular degeneration? And, what do you see, I guess, as the persistent unmet needs in the disease state, even with photobiomodulation that we have now today?
Yeah, some thoughts on this. I believe that with more and more dry AMD patients in the future, more and more will benefit from photobiomodulation as the device becomes more widely available. But because, as Diana mentioned, because these PBM treatments are necessary to maintain and enhance visual gain, so you need repeated treatments, we also need development of cures for dry AMD. And these can reverse the manifestations of the disease functionally and structurally and ultimately benefit the patients the most in the future.
Yeah, fantastic. Marion, you mentioned that the 2-year results hopefully will be published in the near future. I know the manuscript's under revision right now. Where can viewers go to learn more about photobiomodulation and all the related studies that have occurred at this point?
Yeah, until the 24 months publication comes out, the data are and were presented at all important ophthalmology meetings, including the AAO, the ARVO, the Euretina, the Fluoretina, the FASRS, you just name it. But there are also several publicly available interviews and reports on the data. For example, our conversation we have right now, but of course, Ophthalmology Times. I think there's enough information out there if you want to get the data and get the information right now and not wait for the whole publication to come out, hopefully very soon.
Fantastic. And we'll be sure to leave some of the links below so that the viewers can access some of those resources you mentioned. Well, I'm really excited to learn more from forthcoming data, and I want to personally congratulate you three as co-authors on this paper and also your contributions to the field in general. Diana, Nora, Marion, thank you so much for being here today.
Thank you for having us.
Thank you very
Thank you so much.
You as well, you guys. Well, the Retina TL is actually a pilot series, and I'd love to hear if you enjoyed what you just watched. So please reach out via the link below with any feedback. I'm your host, Christina Weng, signing off. We'll see you next time on the Retina TLDR.